Hello again, everybody, and welcome to the Edge of Healthcare. My name is Martin Cody, Senior Vice President of Sales for Fairview Health, and today's podcast is dedicated to leadership at the highest level in a health system. With us to share some of the wisdom and insight of leadership and the path to achieving great accomplishments and helping the patients is James Hereford of Fairview Health Services. James, welcome to the podcast.
Thank you, Martin. It's my pleasure.
I always appreciate CEOs because the old phrase is the buck stops here. So sure, there's a board that you have to report to, I would guess, but ultimately some of the day-to-day operations all fall on your shoulders. So I'm curious, your path, and you can start as far back as you want, and how did you originally get into healthcare?
Believe mine is a fairly unique path because it really started, my degrees are all in mathematics or statistics, and I was working on my PhD in statistics at the University of Washington. We started to have a family. I got very revenue motivated as I was not very well paid as a graduate research assistant at the University of Washington. And I was teaching a course, summer quarter. It was one of those stats for business majors or stats for engineers, one of those things where literally nobody wanted to be there. It's summertime in Washington State, which was gorgeous. And the department chair sent a note around that was from the Boeing Commercial Airplane Group, which was asking for somebody with platform skills who knew statistics because they were starting their 777 build. You can tell this is a long time ago.
Right.
Implementing TQM, and they needed somebody who could teach SBC and DOE. Well, I didn't know what any of that first paragraph meant, but the next paragraph was, and we're paying $50 an hour contractor's wage. So I signed up immediately, went and checked out some books on Durant and Feigenbaum and Deming, et cetera, to try to learn what all this was about. Started teaching, started doing project work. And out of that, because it's Boeing, you have to have your own quality program, and I helped them develop that. I was a consultant around many of their suppliers in the Puget Sound, and just randomly, one of my clients was Group Health Cooperative, which is was staff model HMO. And I didn't know anything about healthcare, but I got into it. And there were three things that were so appealing that I've never been able to escape it, which is more smart people per square unit space than any place. I mean, what's unique, one of the many things that's unique about healthcare is our smartest, best trained people are our frontline employees. Mine are MD, PhDs in large part. The mission orientation and not-for-profit and the sense of obligation to the community and just that spirit that embodies most, not all, not-for-profits. And then frankly, their processes were so bad, I couldn't help but contribute. It was literally a Rolodex organization. And this was still 11,000 people spread around the Puget Sound. But to get anything done, you had to know the person to call. Right. And so I got involved, and I was just going to do it until I could finish my dissertation. They offered me a job, so convert from a consultant. Well, this will be great. I'll do this until I get done. 20 years later, I was still working there, having had this amazing career and really being able to stick my nose in almost all facets of healthcare because it's both payer, provider, right, and all the administrative functions, et cetera. So that's how I started. And then because I could never escape, I went to California, worked at Stanford, and then came here.
Now, were you born and raised out in the Northwest?
No, I grew up on a ranch in Montana. If you've ever seen the Yellowstone, the TV series.
Yes.
That is actually filmed in the Bitterroot Valley, which is where I grew up, a little town called Hamilton.
Oh, wow. So you recognize the importance of revenue at a very early age from that standpoint. And with the advent of a family, you probably also recognize the cost side of the equation very quickly.
Exactly right. Exactly right.
Interesting. And it's funny because you're right. And we talk a lot about on the program with regards to healthcare seemingly have an endless supply of intractable challenges or problems. And even though I think we've advanced from the Rolodex, there's still a large percentage of items that are faxed in the industry. So we have to figure a way to get past that. And you hit upon something which I think is somewhat, your path is correct, is very unique because you didn't come by my dad was a physician or anything like that, or my mom was a CEO of a health system. But you hit upon something I always refer to as the shun philosophy. And people do things more often than not by their inspiration, desperation, or frustration. And it sounds like you looked at this and said, oh my God, this is a nightmare. We need to do something about this, and jumped right in.
Yeah, that was my interests have always kind of tended towards large systems theory, and part of what attracted me out of academia and into an organization was just the complexity of an organization. And it was true, as a contractor, what I could see at Boeing, but man, was it evident as you walk into healthcare and just the sheer complexity. And much of that is just a function of who we are and what we do. Much of it is a self-inflicted wound, right? We make it more complex and many times than it needs to be. Or, our particular sector is famous for how long it takes us to implement things, anything, right? Yep. And certainly the way we've used technology, I was a big proponent of the EMR and helped lead the EMR installation in group health. And I was, excited about the potential because in the paper record world, that paper record was never where you needed it. So I saw this as a great opportunity. The challenge is we didn't really leverage it to unload the burden from our clinicians. What it's actually done is added to the burden. So again, I think you could see this in back in the 1990s. There was a whole literature around the information paradox in other industries, other sectors, where adding a lot of technology wasn't getting better. And out of that came Hammer and Champy and business reengineering. We've never really re-engineered healthcare to the level that we need to. And that's part of what we're focused on in our organizations. How do we really re-architect, create new clinical models, and then use technology to support and remove a lot of the unnecessary activities, the wasteful activities, et cetera, that burden our clinicians and I think contribute in many ways to the burnout that people are describing of how they feel.
No, it's interesting and certainly poignant that you mentioned the complexity of healthcare, and a lot of it is self-inflicted. And I think as we're recording this, we're, within 24 hours on the heels of Walmart exiting the care system and closing 51 clinics because I think someone there said in Arkansas, wow, this is hard type of thing, and realized it. And that's on the heels, obviously, of Walgreens closing, most of their Village MD facilities. So, and I want to get to Fairview in a second, but when you talk about the man-made, self-inflicted complexities, is there anything in particular that you can put your finger on and say, we've got to get rid of this, or this is what we're trying to address here?
Well, I think one of the things that just frustrates everybody, whether you're a patient or whether you're in the ecosystem of care delivery, is just what's the reimbursement economic model that we have, which one could never dream up. You would never sit down and say, I'm going to make up a system. This system is not the one you'd make up unless you were, trying to replicate the, sixth level of hell or something, because it makes no sense. It traps everybody in very difficult circumstances to understand, how do I even judge value in healthcare? So, that's certainly one. But I think it's also a function of, healthcare is by its nature, has been a specialization field. And I would submit that most of the problems in healthcare are not at the point of care. We have dedicated people, experts, decent processes. But when we start to string those points of care together is often where it fails. And we too often put the patient in as the navigator, their own navigator, to try to figure out, I just had a clinic visit, but I arrived at the clinic and they said, well, I had to have a lab visit before. Or I just had a clinic visit and they said, well, you're going to need some imaging studies. Good luck. And then the complexity of that revenue model, because, well, where can I go? How can I go? Is it going to be paid for? What level is going to get paid for? We just don't do a good job of stringing the events together. And I think the additional complexity, there's a stat I saw that I think is so exemplifies some of our challenges. So if you were a brilliant medical student in 1950 and you memorized the entire body of clinical knowledge at the rate it was expanding, it would take 50 years for that knowledge base to double. Okay? Fast forward to today, you're a brilliant medical student, you've mastered the entire body of clinical knowledge. How long would it take to double? 73 days.
Oh, geez.
So this idea, we're generating knowledge so quickly, this idea of the physician as expert, who is all-knowing, all-seeing, has mastered a field, is increasingly difficult to justify because the expansion of knowledge is so vast. And so I think we're also seeing those disruptions. And one of the, I think the most interesting parts about the potential impact of generative AI will be, how does that impact the provision of healthcare? And how does it impact subspecialization and the various ways that we think about delivering care and those care models?
And it's funny because there may not be any hotter topic than generative AI in healthcare right now. Every conference I go to, it's AI is the first 5 things that are on the agenda type. But I also think we should learn from history. And before we introduce this type of technology, and that it's the panacea that some believe it will be, it could also have the unintended consequence, like the EMR did, of creating vast amounts of additional work that I hope doesn't fall on the provider or the physician. So I think you're right, it does have some promise, but AI has been around, I believe, for about 47 years. The first time it was invented at a Ivy League school, think tank, whatever, but now it's coming into its own. But are you using it for anything with regards to patient care or administrative waste reduction at Fairview?
Well, so it depends on, you're right, AI is this broad encompassing term. I mean, it dates back, I remember looking at the myosin, e-myosin studies at Stanford, which was, artificial intelligence.
Yep.
Not well received because it was a functional description. It's trying to actually write out in specific code, how does a doctor think? Kind of a tough challenge.
Sure.
I do think we're certainly, if you're familiar with the Gartner hype cycle, we are on the very peak of the hype cycle when it comes to generative AI. I also believe this is a once-in-a-generation technology that is going to fundamentally transform a lot of what we think about in our society and what we think about from a care delivery system perspective. But the trick and the mistake I think we made with the EMR was we didn't fundamentally think about, how do we re-architect process? How do we fundamentally take advantage of it? If we fail to take advantage and think about generative AI, I think we're going to get the same kind of result. It'll just, automate our ability to produce loads of garbage, that we often see in a clinical note, because people feel like, well, what the hell? I'll just put all this stuff in. It's defensive. If I ever get deposed, it's there somewhere.
Right.
But it doesn't support the clinical activity because you can't find what you need at the next stop in that clinical note. There's a real danger we might replicate that kind of garbage in, garbage out if we're using those notes to train, the new generation of generative AI models. I'm more optimistic than that, but I do think it's something that we've got to be very thoughtful about. And we do use AI, but it's more kind of, I would call it not generative, but functional AI. So predictive algorithms to be able to see. During COVID, we could look at an X-ray of a lung and have a high predictive validity around, is this going to lead to complications, or can this person go home?
Right. Sort of
those sorts of things.
Prompt AI, where you insert a question. Yep. So CEO is difficult of any organization, whether it's a household or a 300 plus location healthcare system. What would you say, or what do you wish someone would have told you 2 years ago about being CEO of a health system that you now know today?
I think there's several things. One is, I wish I would have listened better to the people who did tell me, as a CEO, you're going to spend an inordinate amount of time with your board, like a third of your time. And I didn't believe that. How could that be possible? But I have a great board, but I have 19 bosses, right? So I've got a very large, typical not-for-profit board. And I spend a lot of time interacting with those 19 folks to bring them all along and make sure that they're kind of understanding of our industry, understanding of the dynamics, and able to contribute in a way that really leverages their knowledge. I think the other thing that I think I've always appreciated, but I probably underappreciated it, is healthcare by necessity has to be a team sport. And as a CEO, you are the coach of that team, right? And the big transition for me as a chief operating officer was, I was in it. I was going towards problems every day. I was in our facilities every day. but not just to see what's going on or talk to staff, but really get at, we've got a throughput problem or whatever. As a chief executive, you start doing that, you have to be very careful because suddenly you're doing other people's work and you can't get the kind of talented people you need if you're stepping on their toes and starting to do their work. And so how do you do that effectively? I probably underappreciated. And then just the amount of investment you need to do being external facing, right? Just engaging with the community, engaging politically, engaging at state and federal levels. It's less about you're somewhat the choreographer of a very large symphony or
Right.
a very large dance. But that dance is being produced and you have to talk to every other element of the ecosystem. And it's being produced out in the open with a whole bunch of other people. So that's just the complexity. And the other thing, of course, is you better have a thick skin because, you are the person whose face and whose, name is out there, and people have various opinions driven by politics or, other affiliations they may have that may not love you all the time. And certainly every decision you make's going to make somebody unhappy.
Good point.
Otherwise,
Yep.
the decision would have never gotten to the CEO level.
One of the things that you mentioned, I do hear a lot with regards to wanting to help, and certainly from your operational background and fixing things, you want to dive in and you want to help, but you also have to take a step back because otherwise you'll be doing all the problem solving and that's not what your role is. How do you strike that balance?
Well, I think it's in part get great people and be thoughtful about what do they need from you and what do you need from them, and being very intentional about that. Because otherwise, if the danger is they're expecting you to, be there to be a lifeline, but otherwise give them room, I need to be aware of that and I need to be okay with that. Mm-hmm. Likewise, if they say, look, I need your help here, I need your support, I need a more continual presence. Again, we have to be intentional about that. And, every team member, everyone on my direct reports team, different individual, different backgrounds, different experiences. And so you have to be attuned to those differences. But at the same time, you want a holistic, integrated, well-functioning team. And so you have to bring all those differences together into a soup that actually makes sense, right? And that it works together. And to me, that's one of the fun parts is being able to come to work every day and work with very talented people, but also kind of work that puzzle of, okay, what does my chief operating officer need versus what does my chief of people, chief people officer or et cetera? And how do I interact with them? And then how do I bring them all together into a holistic group?
And did you develop this philosophy just through School of Hard Knocks and going through the process, or was there a management course, seminar, book, mentor, and people that pulled you aside and said, hey, James, here's part of the dance. Here's what many people fail to recognize. Was there anything along the line that helped you hone this philosophy and desire?
Well, I think part of it, I didn't go all the way back in my career, but I started out as a high school math teacher and basketball coach in Montana with my master's degree in mathematics. And so, I have a great appreciation for the concept of coaching and bringing a team along. So at some level that was wired deep in my DNA, I suppose. But, I also came of age in, the wisdom of teams and servant leadership and, all of those books and educational opportunities and mentors. There was a fairly large focus on that, which resonated with me. It made sense. And to me, you combine that with kind of a systems thinking approach and how do work systems actually function or don't function. To me, that's a really intellectually stimulating area. So I think part of it's, I've been lucky. I've had the opportunity to work with amazing people that I've learned a great deal from. And I've been intentional about trying to learn as much as I can as I go along. And also in terms of my choices about where I go work, is it give me the opportunity to learn something. The reason I went to Stanford was I had never worked in an academic before at Stanford. And so I learned a great deal about academic medicine in that time period.
And being in basketball, you probably gleaned some lessons from the Wizard of Westwood because John Wooden seemed to have a good coaching success. And I think still to this day is regarded as the number one college basketball coach in the history of the world type of stuff. And he's got several leadership books that are very foundational to kind of exactly what you're talking about.
Yeah, it's interesting. So my favorite coaches, certainly John Wooden is one of them. And just, again, a person who thought through what's the system that I'm creating and I'm going to put these talented people in. He still went and got talented people, right? Whether it was Lou Alcindor or Kareem Abdul-Jabbar or Keith Wilkes or, all Bill Walton, all these wonderful players. But they worked together in a system that he was very thoughtful in creating. Dean Smith at North Carolina, another legendary coach, same thing. Created a very thoughtful system about how he thought basketball should be played, but more importantly, how do you bring a team together and then go get great players, put them in a great system, great things happen. So certainly influenced me a great deal.
And as it relates to Fairview, give the audience a kind of an overview of the health system and what are the top 3 things you're working on right now in 2024?
Well, so we're about a $7.3 billion healthcare system. We have 11 hospitals. We have, hundreds of ambulatory sites. We have a specialty pharmacy function that's quite good. We have a senior care subsidiary, so we provide skilled nursing, independent living, all the way through skilled nursing spectrum. We have a number of different elements. It's one of the things that attracted me to Fairview. The number one challenge we have is a version of what I described to our board and to our people as the 2%, 4% problem. Our revenues are going up, contractual revenues about 2%, blended, commercial and governmental. Medicare, Medicaid does not pay the bills. We do this cost shifting thing to be able to try to balance that equation.
Right.
Unfortunately, costs go up about 4% per year. So that delta of 2%, that's about $150 million a year. You have to take out of your cost structure or grow your revenue base just to stay even.
It's funny because I was one of those students in statistics for business that didn't like being there, but even I understand that's not a sustainable math problem.
Yeah, I'd say you're going to have a business plan, a business model. Here's your model. Your revenues are going to go up slower than your costs. Go.
Yeah.
Well, that's probably not the greatest business model in the world. And it's the one that we've created this policy of how we've created the ecosystem. And it's going to get worse because commercial insurance is going down. It has been for the last decade in terms of number of people insured. Demographics are certainly going to double the size of Medicare in the next 10 years.
Correct.
Medicaid has become a bigger part of the overall cost kind of expense from a payer class. So for us, a lot of it is just how do we get our cost structure in a place where we can manage our costs in a way that's commensurate with the revenues that we can expect. And we're just not going to see, the government's not going to put a ton of new money into healthcare. Commercial payers are saying, look, no more, don't pass your increases, that make up for all the other deficits in healthcare to us. We can't afford it as employers. So it's on care delivery systems and to a certain extent payers because they control that spigot of the money. And so how do you think about that? But what we can control is our cost structure and then try to engineer better relationships with payers. My ideal world, back to the Seattle days when I said, you sit at the same table with the health plan guy, but you could talk about where do we take that premium dollar and apply it to best effect anywhere in the continuum of care. Well, the problem we have these days is the plans control all the money, either directly or indirectly from the employers. And what we're left is our medical loss ratio. And then plans say, well, we want to do value-based care, which is essentially putting your medical loss ratio at risk, some portion of it. That's not really value. We're not looking at the total premium dollar. We're not looking at how do we keep people healthy in the kind of holistic way that we need to. So I'm also, at some point that kind of relationship has got to evolve.
And it's interesting because you just hit upon a thread that I want to pull on a little bit, because when you say we're not looking at, it's we collectively, you're not singling out anybody by any individual. I'm proposing that there seems to be a genuine lack of leadership at very high levels across the healthcare spectrum. And I see the point of care advancements we've made in the last 30, 40, 50 years have been unbelievable with regards to interventions, therapeutics, and stuff like that. But on the administrative side, on the reimbursement side, we don't seem to actually be making the advancements. And I don't understand if that's a leadership issue, if that's a stuck in the status quo issue, if that is just the way healthcare is. What are your thoughts on that?
Oh, I think it's probably a little bit of all. I mean, there's certainly a policy aspect to this of how we kind of envision this entire system.
Right.
I do think there's a leadership issue. I've always described, as I was coming up, healthcare was an especially permissive environment, healthcare delivery.
Mm-hmm.
You don't get enough money, put up a new tower and stent more people, right? It was a volume-based business. Now that day is come and gone, and back in even with earlier in my career, it was a cost-plus business. Just add up your costs,
correct,
hand them to the payer and say, here. And the payer would just turn around and give it to the commercial, the employer. All that has changed. But I do think it's created an environment that is fairly permissive in terms of historically not being all that challenged in terms of you've got to get better to survive. Well, that's certainly changed. You have to get better, you're not going to survive. Now, every market is different, and every market has, it's easier in some and harder than others.
Right.
The Twin Cities market is a very efficient market. Our reimbursements are fairly low. So we feel the absolute necessity to be able to drive improvement, get better, probably more acutely than others. There's also an element of, I love when people talk about the hospitals are the problem, because 50% of the spending is in hospitals, which is absolutely true. But you look at where the margins are, it's not in hospitals. It's in all the middle players, right? It's the distribution companies, it's in med tech, it's in iTech, it's in payers, that where all the money is made. And that's the other half of healthcare spending. And we've chosen in our particular society to say, not-for-profit healthcare gets certain tax advantages, but in return has to act like a utility, right? Essentially, you got to be there 7/24, got to be available. On any given day, I'm going to have 2 or 3 regulatory agencies in my system telling us how care should be delivered. And you have to compete in a free market environment where you don't have access to capital. You don't have the same affordances and advantages that either for-profit healthcare has or all these middle-tier players have. So at the end of the day, I'm not sure it's a sustainable model, but it does, provide impetus for us to get much, much better, which we have to do. And then it's also consumerism. I mean, people don't know if I deliver great technical quality. They know how we make them feel when they show up.
Correct.
And so you have to be also then provide an experience that people say, yeah, these guys actually care about me and I trust them, because we're such a trust-based business.
No, you're spot on in all of that. It's a great review of some of the challenges, or many of the challenges, but also some of the rewards that are possible, because the trust factor is very real. It's something that is built over time. It's built over interactions and the outcomes of those interactions. And some of the outcomes are within your purview and some of them are not, type of thing. But at the end of the day, you're providing care, and there is a trust factor because, all of us at some point in time are going to touch the healthcare system, coming into this world or leaving this world. So
yeah, inevitably.
I do want to see if you have any thoughts or wisdom to share for someone who is just entering healthcare, and let's say they're on the healthcare delivery system side. What would you tell them as, here's 2 or 3 things to keep your eye on as it relates to overcoming obstacles, having thick skin, those sorts of things?
Well, I've had the privilege of being a faculty at the University of Washington, at Stanford, at Ohio State. When you teach a class, students inevitably approach you and say, well, give me some advice. How do I, advance my career, or how do I get my career going? And my standard piece of advice, and probably it's a little self-serving because it's worked for me. And so, whether it generalizes or not, get involved with the hardest, gnarliest projects you can. Because the advantage of that is a couple of things. One is you're going to learn a bunch of things that if you're just trying to be a functional, leader and move up the pyramid, that pyramid gets steep in a hurry, right?
Sure.
Especially if you aspire to be a, chief executive, part of the C-suite, et cetera. But the advantage of getting involved with those hard projects is it gives you a breadth of knowledge that others aren't going to have. It also gives you exposure in and with the organization, so more people know you. If you're a good, capable pair of hands, that's contributing to important projects that are complex. And, those are the ones that I see and are visible to our C-suite, et cetera. You're then demonstrating, hey, this is a person, keep an eye on this young fellow, this young lady, grab them. There's an opportunity there. That getting involved in kind of volunteering into the hard, complex problems, I think is the best way to make progress in healthcare. The other thing is, you got to take risks. I was on the CEO succession plan at Group Health in Seattle. The problem was Scott Armstrong was my age. And so it was clear, and Scott was very talented, great guy, still is, but retired now. Scott wasn't going anywhere. So that was not going to help me. And I had spent 20 years learning, kind of the HMO business and knew it really well. I didn't know anything about the great unwashed fee-for-service. I didn't know about academic medicine, et cetera. So I was very intentional in going to find an opportunity outside of that very comfortable environment I was in, one I knew really well, to be able to advance my learning. And I think one of the opportunities that I've had and that's helped me is my ability to be able to have experiences in all of these different healthcare environments and then bring those experiences to bear on the current challenges.
Yeah, it's funny how often and consistent I hear that theme. And it can be summarized with get comfortable being uncomfortable and push yourself well beyond your comfortable limits. And it's funny when you say, go ahead and volunteer for the most gnarly, difficult problem, because for all the reasons you said, and I definitely think at the conclusion of those reasons, in addition to you're going to learn a wide breadth of knowledge of the work environment that you didn't know, you're going to get new skills. People are going to see you. That's where the aspect of what you do is far more visible than what you say. And when you start acting in that manner in accordance with throwing yourself in, you're absolutely right. People notice that. And you may not even, more often than not, you won't notice they're noticing type of stuff. But all of a sudden, 3 months later, 6 months later, you'll get tapped on the shoulder and say, hey, would you mind participating in this part of the business? And it happens all the time. And I think that's an incredible piece of wisdom to share. So thank you for sharing that.
Of course. And I think it's, again, selfish. It served me well, but I think it served the people who have asked me that advice over the years, because many of them now are in very senior positions in healthcare organizations.
Agreed. All right, we're going to conclude with the fun aspect of the interview. And this is a word association speed round.
All right.
So I'm gonna mention some things, and you tell me the first word or the first thing, paragraph, sentence that pops into your head. Ready?
Okay, let's go.
Medicare Advantage.
Great mechanism to transfer taxpayer dollars to health plans.
There's a lot of threads I could pull on that there, but we'll save it for the next one.
Okay.
Quadruple aim.
A baseline level of performance that every healthcare organization has to be able to provide.
And it's funny, you mentioned this earlier with regards to medical loss ratio. That was one of the words or one of the phrases I was going to ask you. What do you think of when you think of MLR?
A scheme that maintains the profit margins for health plans.
And it's interesting because we've talked a couple of times during this segment about the complexities that have been introduced. And I keep coming back, and maybe it's the cynicism in me that these are features, these are not bugs from a standpoint.
Yeah, I think that's true.
And lastly, James, if you could sit down and have an adult beverage with anybody in healthcare, living or dead, who would that be and what are you drinking?
Oh, my goodness. I honestly, who it might be? Who's not, this person's actually not in healthcare. Rahm Emanuel. As Obama's chief of staff and the engineering that went into trying to create really the only credible healthcare reform that's been passed in this country over the last 100 years. How did he do it? What was the mechanism? How did the president, all of the players think about that process? Because whether you like the ACA or not, it got passed and it did have a meaningful effect in healthcare delivery. Is it the answer? Probably not. But that might be the one. And what am I drinking? Well, probably whatever Rahm's buying.
You, as a former Chicagoan, you might be on your own there. This has been outstanding, James, and I really appreciate your involvement and certainly the wisdom you shared. A lot of great tips here, and we're wishing you and the community nothing but success up there in Minnesota. Appreciate the time today.
Well, Martin, thank you for asking, and thank you for doing this. I mean, the kind of pay it forward element of this podcast is, I think it says a lot about you, says a lot about what we need is we need talented people coming into healthcare because we got hard, serious problems that are critical to.
Our pleasure. We'll chat soon. Appreciate it.